All right, good evening, everyone. We'll start in a couple of minutes. It's January 18th, 2021, week 3. This is Medical Terminology, MED120, and I'm your host, Dr. Nelson Garais. And I'm gonna take down some attendance real quick, and then again, I'll check again the attendance. So I have Miss Aaliyah, Miss Bangura, Miss Pericles, Miss Vargas, Miss Brown, Ms. Tolef, Ms. Tarawali. Okay. Okay, and that's 1, 2, 3, 4, 5, 6, 7 plus me. That's 8. Okay, so if there's anybody else, I'll check in a moment. And like I stated, for if any of you are looking at this as a recording, this lecture was announced over the weekend. So, and remember, in order to get attendance, if you missed this class, please contact me because I have to put in attendance for this class by like tomorrow, 12 noon. So if you missed, please contact me and I'll get a mini assignment so that we can justify the attendance. All right. Already 6 p.m. Let's start the show on the road. What is due today or tonight, right now actually, which is now 5:59, running into 6 p.m. Anything that's week 2 or module 2. So what's due? The Medical Language Laboratory, critical listening exercises 1, 2, and 3, response exercises 1 and 2, and that's for chapter 5, the cardiovascular system. Make sure you do your quizzes and of course the discussion forum. And those of you, if you see a grade of 100 and sometimes I'm moving a little bit fast, you see a grade of 100 and you see no comments, that means everything is good, okay? But if you see a grade of 100 and there's comments in there, please take a look at it because it's something to look at in order to enhance your future your future classes. So it is now already week 3. Time flies. It'll be quicker before it'll end quicker before you know it. So what's this week? What we're going to do, if you look at module 3, it's chapter 4, the respiratory system. So next week, critical listening exercises 1, 2, and 3, response exercises 1 and 2 are due for chapter 4, respiratory system. And I'll be grading week 2 items later this evening. And of course, there's an associated quiz, and the quizzes are really quick. And discussion forum for this week will be, I'll put something in here later on this evening. I haven't decided what I wanted to have as a question for next week. But again, back to the format, 200 to 250 words, and make sure you have at least one 7th edition APA formatted citation, and make sure that the citation, you mention it somewhere in the in your submission. So let's go to Medical Language Lab 3. Close this out and do this. And why do I always forget to do it on, for those of you Mac users, for whatever reason, Safari is glitchy for Medical Language Lab. So I find it best to be in, Google Chrome or Firefox. Now, we'll go here, go right into our ebook, go right into chapter 4. Now, respiratory system. Again, that is another sub-department of the Department of Internal Medicine. And take this down, put this down. If we could see here, the first thing that we always discuss are who are the people in the neighborhood. So the specialist is the Department of Pulmonology, which is a subspecialty of the Department of Internal Medicine, also known as pulmonary medicine. And that person already went through 4 or 5 years of internal medicine training and then went through another 3 years for pulmonology training. So they are the experts of respiratory disorders that deals with everything that you see in this picture here. You have the upper respiratory tract, which is upper, which is everything up here. And then the lower respiratory tract is from your trachea, which is your windpipe, on down. All the things we're going to be talking about in the upper respiratory tract, there's things that, yes, it's not good for the human being to have a pathology up here. But if the pathology is down here in a lower respiratory tract, that's already danger. This is the kind of thing you get admitted in the hospital for. Up here, this is when, but everything that's up here can progress to down here. So that's something of concern. And at the end, in our lower respiratory tract, at the end of all of this tubing, you have these little bunches of grapes called alveoli. And this is the section, and here's another one. This is the section where there's gas exchange. There's 2 gases that our body needs. You need oxygen because we need that for fuel. But then once the fuel gets used up, the exhaust or the byproduct of metabolism is carbon dioxide. So you have to get rid of carbon dioxide. So carbon dioxide has to go in our lungs so we can exhale it. And oxygen has to go in our lungs and then into our capillaries here and into our blood so it can be transported by our red blood cells to all the parts of the body that need it, right? If either function, oxygen coming into the lungs and carbon dioxide going out of the lungs, anything, because that is the whole function of all of this, is for that gas exchange. I take in oxygen and I exhale carbon dioxide. And up here we have the upper respiratory and down here the lower respiratory. So just a quick anatomy and physiology, and just so I could show you why they separated the upper respiratory tract versus the lower respiratory tract. So if you have a URTI, you have an upper respiratory tract infection. So you can have an itis of any one of these things. And if you have a lower respiratory tract, you can have an itis or some kind of inflammation or infection of anything that are down here. And then you could see here the more serious stuff like pneumonia, pneumonitis, bronchitis, right? All these scary things that are on our lower respiratory tract. But if I had adenitis, right, my adenoids are their lymphoid or immunologic tissue that are in my throat, I just remove them. And adeno means gland, oid means something resembling it. So it looks like a gland, but it isn't. It's actually immune tissue, and I could remove it, as in adenoidectomy. Your larynx, which is your voice box, try to distinguish that from your pharynx. Now, your pharynx is your throat. Your larynx is the voice box. So if you have laryngitis, and I could see that on a laryngoscope while I'm performing laryngoscopy, right, you will have aphonia. Let's look at that word. So laryngitis, pharyngitis. So if I had laryngitis, I have inflammation or infection of my voice box. And if my voice box gets affected, I won't be able to speak too well, would I? So I'll have aphonia, right? Or dysphonia. What do you do on a phone? You talk. So it's a state of condition of A is your prefix, meaning no or not, and phone, right? Phonation is speaking. So when you have laryngitis, that's when you can't talk, right? And then same thing with dysphonia. When you talk, it hurts or it's abnormal. So state of abnormal speaking, okay? Like where you have a crackle in your voice and it hurts, you know, and you got a really bad throat, really bad sore throat, but a sore throat is pharyngitis. It could be pharyngitis and laryngitis because they're two entirely separate things. And if you could see here, this is the cricoid cartilage of your larynx. See here, it's cartilage here, right? And then here's your pharynx, which is your throat. So you can have an infection here and here, and that will be laryngo, or pharyngolaryngitis, or laryngopharyngitis, either way, all right? And the oral cavity, right, oro. So nasal cavity, right? Nasal, al, pertaining to your nose. If I had rhinitis, inflammation or infection of my nose, rhinorrhea will be, when your nose starts dripping endlessly, watery discharge because of rhinitis or inflammation or infection of the of your nose. Rhinitis is a common diagnosis for any upper respiratory tract infection that gives you rhinorrhea or watery discharge. Most likely it's viral. And what do I mean when most likely it's viral? Because typically a virus, other than, nasty corona or SARS, typically a virus, if you're relatively healthy, it'll go away in the 7 to 10 days. It's what they call self-limiting. You don't need any meds. You just need to take care of yourself. Take a couple of days off of work and plenty of fluids. Tonsils, your peritonsillar area. Peri is the prefix meaning surrounding. So around the tonsils in your throat, you could have inflammation or infection, and that will give you some sore throat there as well. Now, the danger zone is your trachea or your windpipe. So if, let's say for example, it gets blocked, I have to form an opening. And in order to do that, I cut into it. I perform a tracheotomy in order to form a stoma or an opening called a tracheostomy. Notice that tracheotomy, I did the cutting, and then tracheostomy, I put in this little tube thing, and there's a picture of it momentarily as we go down the line in this textbook. And you could see all of those terms that we just talked about. That's all upper respiratory. Now, from the trachea on down, that is lower respiratory. We talked about those bunches of grapes, these things. These things are called your alveoli. That's plural. Alveolus is just one of these right here, right? Alveolus, just one of these little grapes, but a whole bunch of grapes. Plural is alveoli. And your alveoli, they're really important. So if I have any itis in that section or any lower respiratory tract infection that'll affect my alveoli, you're in a lot of trouble, because then you can no longer have gas exchange, and that is not a good situation to be in. You could also have bronchiectasis, dilatation or expansion. This is usually secondary to emphysema. Now, you may think like, hey, that might be a good thing if your lungs expand, but remember, your body likes being normal, likes being in the middle. It doesn't like when things squeeze, like bronchitis. It doesn't also like when things get dilated, like bronchiectasis. In both situations, the oxygen gets restricted. So if a patient has emphysema with bronchiectasis, that's not a good situation. They're not going to get enough oxygen. If my patient has bronchitis, right, and it's going to have a buildup of tightness in their alveoli and a lot of mucus, that's also not a good situation. And one way we can look at it, we could use this instrument called the bronchoscope, and I will schedule a bronchoscopy in order to check what's going on, especially if I have bronchiolitis. You see in the tubes up here how this is your right and left mainstem bronchus. It's like pretty big, and then it gets smaller, 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 and smaller. Now, when they get smaller and smaller and smaller, they lose all this cartilage here. So that means it doesn't stay open. So it gets replaced with all this smooth muscle and mucus. And that's when bronchitis really does a number on you. Or let's say you have an exaggerated immune response, like an asthma. And then you'll get bronchiolitis, bronchitis secondary to asthma. You have a covering of all your lungs. Those of you who went through anatomy and physiology and cut up a lung with me, you have your pleura, which is the covering of the lung. It's a two-layered covering, and you could get a pleuritic rub. Pleurisy is, you guys remember the last time you had a bad cough? Now I'm coughing. last time you had a bad cough, you ever had like it hurt so much that it felt like it was scraping on your chest like a knife? Well, that's pleurisy. That's when your pleura get infected and you get pleuritis, also known as pleurisy. Pneumonectomy, we can actually remove a lung or part of it. Ectomy means excision, to cut out. So if you have like severe lung cancer and it's really invasive to the lung, we got to take out a chunk of it, and that's a pneumonectomy. You could also have pneumonitis, inflammation or infection of your lung. Pneumonia, now that's a serious infection. Of course, it could be from a bacteria, it can be a virus, it can be from a chemical irritant. But remember we talked about that your lung, like your body likes being in the middle. Your lung doesn't like when it's dry, nor does it like when it's wet, as in swimming pool, there's a fluid level in your lung. Both situations are very bad for your lungs, are very bad for breathing. That's why when you get pneumonia, it's serious. And it is a lower respiratory tract infection, just like bronchitis, just like emphysema, right? And by the way, bronchitis and emphysema are part of COPD, or chronic obstructive pulmonary disease, right? Chronic meaning ic, pertaining to time, meaning it takes a while, right? But pneumonia could also be acute, meaning you could get that really fast. Last time I had pneumonia, I wasn't feeling good, and on a Thursday, I got a high-grade fever Friday night. By Saturday morning, I can't breathe. I was admitted by Saturday noon, right? And there was already a fluid level in my right lung, and that's called pneumonia. Pulmonologist, pulmonology, right? Those are the specialists, the practitioners, right? And of course, there's a subsection of the Department of Internal Medicine. That means these people are MDs. Thoracopathy. Pathy means disease. Any disease that's in our chest. So not only your lungs, but your heart as well. So if you have any thoracopathies, we also consider that as well. Alrighty, suffixes, or the last parts of certain words. Remember our pleura, the covering of our lungs? Remember pleurisy? Yet another word for that is pleuralgia. Algia means pain, right? State or condition of pain. And pleur means your pleura, covering of your lungs. You could also have thoracodynia. That means chest pain. It could be from your lungs. It could be from the part of your trachea. It could be from a whole bunch of things, even acid reflux. So that just means pain in the chest, and it's non-specific. Remember we talked about bronchiectasis and a dilatation or an expansion, right? Atelectasis is the dilatation of your alveoli to the point where they collapse, and that's not a good thing. And again, bronchiectasis and even severe atelectasis, expansion to the point of collapse of your alveoli, that is part and parcel of one of your chronic obstructive pulmonary disease called emphysema. The other COPD is chronic bronchitis. Osis means abnormal condition. And you know, if you're not breathing well, you get a little bluish or get a little ashy, and that's called cyanosis, okay? Especially when you see it around, you can drop down, your eye or look at the inside of your lip. And when that starts having a bluish discoloration, that means that you have cyanosis. Odds are your pulmonary system is not doing right by you. If I have that nasal drip, or maybe I have some sort of nasal obstruction, I could have anosmia, right? Ia, state or condition, and prefix of no or not. Osm means smell. So anosmia also could mean, if it's not temporary, it also could mean you have a neurologic. It could be a neurologic problem. Hypoxia, right? That is state or condition of oxygenation. That is hypo, meaning decreased. And hyperoxia is also not good as well. We need to be in the middle. That's why there's only 21% of oxygen in the atmosphere. If I flooded the room with 100% oxygen, we'd all be blind in an hour, right? Too much oxygen. You could also have a situation where too little oxygen right here, and that's hypoxia. And definitely that's the biggest thing that we're worried about. You know, when we put that little monitor on your finger, right? That's your pulse ox or your pulse oximeter. It has to be above 97%. If it's not, you got some problems. Phasia, aerophagia, especially, you know, you typically breathe through your nose, but if it's so bad, the coughing and everything, you're breathing through your mouth, it causes a whole bunch of problems. And this happens especially with infants, right? NIA. Let's look at this NIA. Let's break this one down. Because NIA means breathing. I could have hypernia, state or condition of breathing, too much breathing, right? Also known as hyperventilation. I could also have hyponia, too little, right? Also known as hypoventilation. I could have hypercapnia. That is too much carbon dioxide in my breathing, right? And carbon dioxide is written like that. It's written like CO2 with a little thing like this, like a subscript, okay? And O2 is just written, you know, that same way, O2. And remember, I need oxygen, O2, and I need to get rid of carbon dioxide. And again, it has to have a specific rate. So NIA, think breathing. Too much breathing, too little breathing. Hypercapnia, too much carbon dioxide in my lungs. Not a good thing, because then it'll tell everything to slow down. And you'll, for those of you who took anatomy physiology, I hope you remember how that went down. And those of you who haven't yet, just know that it isn't oxygen that your body really monitors. It's carbon dioxide. Specifically the cerebrospinal fluid. That's the what do you call that? The chemical monitoring system for your breathing. Pharyngospasm. All of this stuff here are lined. You see, it's all pink, and especially the inside parts here of your bronchioles, the small little tubes are all in here because it's like a tree. It gets smaller and smaller and smaller. And all of these muscles here, we don't really control them. So you could get a, let me write down, Francis. You could get a spasm. And those of you who have, what do you call that? Asthma. Let's say, for example, a normal person gets exposed to some heavy dust. What happens? You cough it out, right? We're done. You have a cough reflex, a gag reflex, and it pushes everything out. But someone who has asthma, asthma is actually a kind of, in a way, a form of an autoimmune where your body has an exaggerated response to allergens. So that same dust that with a non-asthmatic patient didn't bother that patient too much, that's when the patient will start wheezing and coughing, because all of these tubes here will start squeezing, and then it'll produce way too much mucus. Like I said, exaggerated immune response, and that's in asthma. So they could have significant broncho and pharyngospasms in asthma. And we already talked about thorax, which is your chest. So pyothorax, pyo is pus. And what pus is every time you have, infection, there's always, in a battle and in an infection, who's going to war in an infection? You have white blood cells and whatever pathogen, right? Well, there's going to be dead things. So dead white blood cells and dead pathogens form pus, and we got to get rid of that. So if there's pyothorax in my patient's chest, I'm going to have to do a chest tube, and then I have to remove that fluid, and that term is called Drum roll, please. Thoracentesis. So that's what? It's a surgical puncture to remove fluid, thorax from your thorax or your chest. Now we saw that in my notes as well. We also had amnio. What's with my typing today? That's surgical puncture to remove fluid from mommy's amnion. And this is for testing for neural tube defects in pregnant patients. Then we have arthrocentesis, surgical puncture. Oh, I'm gonna have this, I think, in a couple of weeks. Puncture of a joint space. I hate that because my gout has been kicking up, and my rheumatologist has been hinting that I might have to do this. I did this 2 years ago. My God, I was seeing stars. So painful. But hey, these are centesis, and you can see how we can build these words. And I believe 2 out of these 3 are in the notes from week 1. So, Mr. Francis, what do you mean by, does it have anything to do with thoracic? Yes, because what's thoracic? Pertaining to thorax or anything in your chest. So if I did a thoracic tube, right, or what they call thoracic breach, I'm putting a chest tube in my patient, right? Let's see. Okay, let's see with this. Here's your sinuses. If you have sinusitis, you guys know, how does that make you feel? Makes your head feel like a bowling ball. Because in your skull, you have spaces, okay? Now, you have like rhinitis and an upper respiratory tract infection, right? All of these spaces might be filled with some fluid or some pus. And then you start talking like this because you're all gummed up, right? And here's a neat thing that you could do diagnostically. You take a pen light and you put it right here on these parts of your face, and you'll see that the red glow isn't as red. It'll be like a dark red because it's all filled with fluid. But you know when somebody has sinus or sinusitis, and again, that is a upper respiratory tract infection. You're not going to die, but you're going to feel really crummy for a while. Now, paranasal sinuses. Here's your nose, nasal. Para means alongside. So paranasal are the sinuses that are what? Like your sphenoid and your maxillary. And notice they're named after the bones. Here's your frontal bone, so you have a frontal sinus. You have a sphenoid bone, you have a sphenoid sinus. And you have your maxillary bone, that's with your maxillary sinus. And all that the sinus means is there's spaces, okay? And whoever built us perfect, because your head has to be light. And also, those of you who are really into speakers, take a good look at the inside of your skull. It looks like a Clippich high-end $3,000 speaker, because that's why when you sing in the shower, that's why your voice sounds so awesome to you, not to the rest of the world, because it is now running through the best speaker the world has ever created, which is your skull. But those of us who know, who have sinusitis, this fills up with water or pus, then it doesn't get so good. Here's that same picture that we showed before with the upper respiratory and lower respiratory. This is a nice picture for anatomy and physiology. A and P, this is what I do. I just do A, B, C, D, E, F, G, same thing, right? Arrow, stenosis, stomy. Let's see. Any other words that are? Oh, remember that stoma we were talking about? In order for me to get the hole, I have to perform a tracheotomy. Tomy, to cut into the trachea. But then we have to install this tubing here and tape it down or sew it down, and that's called a tracheostomy. So stoma means hole. Tomy means to cut into. So in order to do a tracheostomy, I have to do the tracheotomy first. And then we do an expanding balloon here so it doesn't move around. Then we either tape it down or sew it down. I like sewing it down. It's really in there. Remember we talked about pneumonectomy? This is the neat thing about your lung. It's in lobes. It's in sections. If you notice, there's only 2 sections on your left lung and 3 sections on your right. And your left has this little notch here where your heart fits. Because remember, your heart's a little bit towards the left. Remember, you're always looking at the perspective of the patient. So this is the right lung, this is the left. And these are different types of pneumonectomies also, and you could remove an entire lobe or entire section of your lung, and that's called a lobectomy. Pneumonectomy is the entire lung, either unilateral or bilateral, and if we do bilateral, you'll be hooked up to a mechanical ventilator, also known as a mech vent, for quite some time. Here's your CPAP machine, right? Continuous positive airway pressure, or known as CPAP. These are for people who have, remember the soft tissue and the muscles we talked about? Sometimes in some people, there's some obstruction and they got some, they have some, what do you call that? Stenosis or collapse of some of these pathways. My nephew, he refused to get any of the surgery or whatever. He's like, he's in his 30s and has to sleep with these things on. And these things are prone to infection. But yeah, they're wonderful devices because they force air through here so that the patient can breathe when they're sleeping. Because you know, when you're sleeping, all these muscles, they relax. That's why when you have, sometimes when you have somebody in your house who has a deviated septum or, you know, some sort of obstruction, especially secondary to maybe class 2 obesity, that's when they snore like, oh, my sister, before she got it fixed, I could be in my basement and she would be upstairs on the second floor and I could still hear her snoring. But then she had you know, she had the surgery and then it cleared all that. See this? It cleared all this obstruction. She had obstruction here, the upper turbinates, and also down here. So when you're sleeping, it flaps and then makes a horrid noise. And you can get any infection from CPAP, most likely mycologic, because think about it. You're breathing. Your mouth is a nasty place. You could brush it with gasoline, but you could also look up what's most common. But my patients, the fluid that gets in here sometimes gets stagnant, and you know what happens with and you can get a mycologic, which is mycology, low G, study of fungus, right? So you're constantly clearing this out. And nowadays they even have these really neat UV packages where you put the whole entire tubing in there, and you got to UV it while you're not, you know, while you're awake. So when you wake up, it'll be all nice and neat. Here is a thoracentesis, right? We use what we call a thoracotomy kit or a cut down kit because I'm Tommy, I'm going to cut, right? Sometimes I have to cut, and if this pleural effusion gets really pussy, I really got to cut, and we use something that's got even a bigger needle, and it's called a trocar, and that's some mean stuff. And we got to be very, very careful because in your ribs, do you have an artery, vein, and nerve in there? And if you poke that, not a good thing. By the way, this collecting bottle is in the wrong place. It should be on the floor because we're gravity feeding it to the bottom. And it has we can't violate, like you can't open this to air, because if you open the lungs to air, you'll find out in your anatomy and physiology class, you're going to mess with the pressures, and then you're going to collapse a patient's lung. I've done that once or twice. It's not fun. Oh, here's the COPD I was talking about, chronic obstructive pulmonary disease. So that means chronic. These diseases take a long time to develop. Obstructive, it's going to block what? Your pulmonary, your lungs, right? And that's called COPD. The two classifications are emphysema, 9 times out of 10, it's almost always smoking, and asthma. Also chronic bronchitis as well. So that's a trifecta. And in chronic bronchitis, you have inflammation and infection of your bronchioles, which is these little tubing here. And then you can see also all that pus formation. Same exact thing for asthma, but with asthma, the big thing is the constriction of the smooth muscles because of the exaggerated immune response. And emphysema, the big thing is the atelectasis or bronchiectasis that will occur, the abnormal inflammation and distended bronchioles, bronchiectasis, and alveoli, atelectasis. And this will collapse. And that's not a good thing. And emphysema, think it's 9 times out of 10 smoking. Hey, doesn't this look like a beautiful all of the above anatomy and physiology question? Doesn't this look like also a beautiful all of the above if I'm asking, what is COPD? Is it emphysema? Is it A, chronic bronchitis, B, emphysema, C, asthma, D, all of the above? Doesn't this look like a wonderful all of the above picture? I think so. Pleural fluid, pulmonary tech can do it. Nurses can do it. The whole bunch of people can do it, but if it's really serious, the MD will do it. During this time now, we don't like a lot of the MDs have to get their hands dirty. Now, emphysema, like what I stated earlier, it is the expansion, the abnormal expansion due to the damage of all of this tissue. Because when you smoke, all that chemicals get in here and messes with this, right? And then these things start abnormally expanding. And that's what? Atelectasis and bronchiectasis. Hold up, my kids are being noisy. Hey, I'm teaching. All right. Okay, back to business. So, and then you're going to get more when you're anatomy and physiology not really regarding the pathology, but definitely when you're in your pathology class, you're going to know all the ins and outs of how this happens. But emphysema, it's typically some sort of outside chemical like smoking, asbestosis, pneumoconiosis, like if you have coal miner's lung, that kind of thing, right? And asthma, think exaggerated immune response, and chronic bronchitis, that could be a whole bunch of things, but usually means some sort of immunodeficient state, chronic bronchitis. Also, there's something called Pickwickian syndrome, where, you know, if your stomach's too big, it pushes up and increases pressure against your lungs, and then you have a really hard time breathing, and that could also cause COPD as well. And that's relatively common. So let's look at this. These are abbreviations, and we talked about last week that, yeah, JCO doesn't like abbreviations, but guess what? We need to know them, and you'll see them again. My MED120 pharmacology class, every week, we're always doing abbreviations, especially when we're looking at prescriptions. ABG means arterial blood gas. That's when we get arterial blood and we look at the gases. And the two gases that we really, that are important are oxygen and carbon dioxide. AIDS, that's easy. ARDS, acute respiratory distress syndrome. Now, unlike COPD, ARDS happens overnight. Classic example is baby has a low-grade fever, like at dinner, and then during the evening, it progresses, and then baby can't sleep, has a cough, and then goes into respiratory distress come early morning hours. It happened within 12 hours. It's very fast. CA, I like cancer. I don't like these other things. I don't use CA, and I haven't seen CA used for chronic old age or cardiac arrest. It's always for carcinoma. CF, cystic fibrosis. Now, cystic fibrosis, remember, if all that mucus gets in the way, and also that mucus has a bunch of fibers in it, how well can you breathe? Not very. So cystic fibrosis, the big thing is There's a osis, abnormal inflammation and infection, that causes fibers, and a lot of cysts, a lot of infection. And you know, when there's infection, there's white blood cells that get beat up, and then you get pus. Carbon dioxide, COPD, CPAP, CT scan. We could do a CT scan of your lungs. That's a computerized tomography. Let's look at that word, tomography. Tomo means place. Graphy means the process of recording it. So the CT, it's like this machine that shoots multiple X-rays at you, like anywhere from like 32 to 64 little little plates, and then you put the plates together, and it has a wonderful 3D image. The cool thing is you get a beautiful 3D image. The bad thing is that you're now subjecting your patient to a whole bunch of X-rays, which isn't fun. DPT is diphtheria, pertussis, tetanus. It's an immunization. Nice to know. Diagnosis, we already went over. DX, know the difference between diagnosis and prognosis. EEG, we already went over. Electroencephalogram. Now, ET, now we don't call it ETT, I call it ET tube, because endotracheal tube. That means I want to open up your airway, endo, right? And I want to put the tubing, endo means it means inside. Inside where? The trach, right? So let's say, for example, let's look at it. Let's look at when we're looking at this ET tube. Here you go. Let's say, for example, my patient isn't breathing and we're going to have a hard time, right? We, of course, just like CPR, we hyperextend the neck if we can, right? Because then we put in this tube. This is an endotracheal tube. Endo meaning within, trachea, of course, it gets in here. And then once it gets in here, you have this other port where we take a syringe and then we blow this up and then with air, and then we secure it right here onto the patient's face, right? And then we could either put, we of course ambu bag the patient, and you know, has that big bag, and then we connect it to your oxygen tank. And that's what an ET tube is. FVC is forced vital capacity, nice to know. Now bicarb, definitely need to know that. That's a buffering system in your lungs. I mean, not only in your lungs, in your blood and everywhere. There's no abbreviation for cardiac arrest. It's just, we just say it's cardiac arrest or just arrest. Nurse should be able to conduct an intubation. Definitely. Should be able to also do it blind without scope. But the people who are best at it are emergency med and any emergency like EMT deltas and paramedics. I got really good at it when I was an EMT delta. And it was really neat. For those of you who work in the field already, if you work in the field before and you see things before, when you get to an advanced level, it becomes old hat and becomes easy. But man, that's some rough stuff doing a blind ET. Because sometimes you have to do it blind because there's so much trauma and there's so much blood. And even if you suction it all out, it's just a mess. HF, heart failure, right? CHF, you might see it, is congestive heart failure. That's when congestive heart failure is when, remember I told you that even though we study all these classes separately, everything's connected. Your lungs and your heart are connected. So if your lungs fail, let's say you have really, really bad chronic bronchitis, you have really bad COPD, it's going to mess with your heart, and then you could get CHF, or congestive heart failure. And heart failure in general is pretty much shock, the inability of your cardiovascular system to do its job. MRI, magnetic resonance imaging, that's neat. We use this big, huge magnet. NMT, sometimes they use that, you know, but we just say nebulizer. O2, of course, OSA, obstructive sleep apnea. Sometimes they use OSA, SA. Nice to know. This, need to know. When you see PCO2, PaCO2, PCO2, that has a meaning. It means PA is partial arterial pressure. of your carbon dioxide. PCO2 is partial pressure of your CO2 in general, or it could be also capital P CO2. Um, what do you call that? Gases like oxygen and carbon dioxide are measured in either percentage or pressure. And when you do your arterial blood gas, you need to know those numbers. And for you future nurses, you better know how to do the calculations for it. That nurses get less and less. They'll do the arterial blood gas, the ABG. Even techs get to do this less, but the doctors, the pulmonologists will get to do the ABG. But when the pulmonologist needs the numbers, they call the nurse, and the nurse should be able to interpret. And that's a big future NCLEX question on the interpretation of arterial blood gases. So if you're in anatomy and physiology, we briefly touch on it, but really look at that in that lecture, in the pulmonary lecture. PCP. PCP could mean phencyclidine, which is angel dust. It's a rarity. Only complete lunatics will do PCP nowadays. But PCP means pneumocystis carinii pneumonia. It is the type of pneumonia that you only get with HIV/AIDS patients. It is serious and it is deadly, and it is a rough way to die. You die essentially drowning in your own tissue fluid. PE usually means physical examination, could mean pulmonary embolism, but I like PE for physical examination. PFT, pulmonary function test. That's when we make the patient breathe into this machine, and it gives us all those lung volumes and lung values like this FVC here, forced vital capacity. And you'll learn that all in your future nursing classes. pH is the degree of acidity or alkalinity, but it's actually a formula, the negative log of the concentration of the hydrogen ion. You'll learn that in anatomy and physiology. PSG don't usually do SAT, saturation, like O2 SAT, CO2 SAT, and usually we'd look at oxygen saturation. It's how much your arteries and your tissue take in oxygen, and that's O2 SAT, and that's important. SIDS, sudden infant death syndrome. That's like, there are some papers that say ARDS is a precursor to SIDS. That's why you try not to have babies sleep on their stomachs. Some other, especially premature infants, since the neurologic and their pulmonary aren't fully developed, sometimes they just die, and that's called SIDS. But ARDS is also acts just like SIDS. SOB doesn't mean son of a beehive, it means shortness of breath, also known as dyspnea, or abnormal or difficulty breathing. And of course, TB is tuberculosis. And by the way, again, I go back on my soapbox. We're all worried about corona. This thing kills way more people in the world. But yeah, it kills only poor people. So people don't look at it as much. I used to be on the World Health Organization task force on tuberculosis for 2 years, and garnering funding was like pulling teeth, because who wants to go deal with it? Nobody. Does endotracheal suggest endoscopy? No, two entirely different things. So we look at it endotrache, right? Endo means within, trach means your windpipe. Endoscopy means scoping. Scope is using an actual tube with a fiber optic. Your ET tube is just a tube. And that endoscopy is different. And endoscopy requires a patent trachea. When you do an ET tube, your trachea failed on a whole bunch. Your trachea and your lungs are failing on a catastrophic level. And that's why we put the ET tube so you can breathe. When we do an endoscope, that's when we, what do you call that? That's when we want to look and maybe even get a biopsy of what's inside. Acidosis, alkalosis, osis, abnormal condition of too much acid or hyperacidosis. Alkalosis, too much base. Because remember, when you have the pH scale, you should be in the middle. We talked about ARDS. We talked about this stuff here, nice to know. These are the different adventitious breath sounds. These are abnormal sounds. So if you hear rhonchi, rales, stridor, or wheezes, these are abnormal things. Anoxia, bad news. means my patient is getting no oxygen. Coryza, it's upper, not, the term isn't used as much as it is used to, but it just means a lot of postnasal drip, and it is related to a common cold. But if you want to code for common cold, 9 times out of 10, we always use the term rhinitis, or inflammation or infection of your nose. Croup, respiratory syndrome, you have a laryngeal obstruction, spasm. Cystic fibrosis, we mentioned. These are nice to know. Hypoxemia, blood condition of what? Hypo, low oxygen, not a good thing. Hypoxia, state or condition of low oxygen, not a good thing. Lung CA, right? You can see it here, is carcinoma. Lung CA is not good because it is, I can't remember, I forgot, it's the #1 killer in women, but I think #2 killer in men, something like that. Pleural effusion, pleura, right, inside, and there's effusion, there's water, and that's never a good thing. Now, CPAP and nebulizer. Remember, the CPAP, if we looked at the picture, why should I go find the picture? Let me just go look at a picture. CPAP is this whole entire machine, right? This whole entire business to continuous positive airway pressure, to force oxygen through your passageways and into your lungs while you are sleeping. That's what CPAP. Now, what's a nebulizer? Nebulizer, or your puffer, is a drug delivery system, right? So the nebulizer, what it does is it kind of like heats up, mystifies the air and puts a lot of like warm humidity through your lungs, so it'll open everything up. And if you see this little thing, maybe we could, yeah, here, right here, you see this little thing, this port right here, we put medication in there. In a CPAP, I'm not putting any medication in there. I'm putting just air, forcing air. But here, the nebulizer, I'm trying to loosen up the mucus, giving you warm, medicated air through the system. By the way, my cousins, maybe you see this now in CVS. Now they're competing against a lot of South Korean and Chinese companies. My cousins were about 15 years ago. If you've ever seen the one for kids that's like a frog or like a chick or a duck, they were the ones who put that to market. And they did a really wonderful job selling it to CVS and Walgreens. And like I always say, it is not where you went to school or what you did. They make more money than I do, and I have an MD, and I have way more medical experience, but they took their experience with children about 15, 16 years ago and said, hey, these kids get scared. So they made this into like different barnyard animals or something like that. But that's the difference between a nebulizer and a CPAP. CPAP doesn't deliver meds. Nebulizer delivers meds. And not only delivers meds, it humidifies the air going into your system. And that humidity loosens up the mucus and then opens up the bronchioles. Really neat stuff. Pneumothorax, this is not a good thing because pneumo means air. Now, we need air inside the lungs, but if there's air inside my pleura, it's going to push against my lungs, and that's not a good thing. Hemothorax is blood, right? So I could get either way. I stab this dude, what's going to happen? There's going to be excess pressure onto the lungs once air and blood get in there. So don't get stabbed or don't get shot. That's a good thing. Bronchoscopy, this is when I scope the patient and look in their lungs. And these tubes, also I could do biopsies and take little bits and pieces of things. And the neat thing about bronchoscopy and any of the scoping that we do in medicine, there's a lovely video. So let's say I'm pretty good at this, but then I have a consultant with 45 years. I can email them now the video, and then they could give me a wet read that day, which is really neat. Polysomnography. Somno means sleep, right? So this is called a sleep study. And then sometimes we hook up EEG to you because it might be a brain problem. And then we hook up sensors because it might be a breathing problem. This is spirometry, also known as your pulmonary function test or PFT. Spiro means breathing. Metry means the process of measuring. So if you've ever been to Falls Church, there's this nice little, looks like a little mini laptop, and then you breathe into it and it shows you the lung pressures. Another endotrache intubation, or when you scope the patient, see this blade right here? Usually has a little light. It's pretty neat. Bronchodilator, that's a drug that will dilate or open up the tubes in your lungs, right? Corticosteroids, remember we talked about the asthmatic patient, they have extreme itis or extreme bronchitis. Well, we give corticosteroids to severe asthmatic patients so it gets the inflammation down so they can breathe. Mucolytic, it's a drug that breaks down, lysis, breaks down the mucus. I don't like that because mucus is good. The best thing to do is drink lots of water so it makes the mucus runny so you could spit it out. Nebulized mistreatments or NMTs. Now, here is your inhaler. This is also another medication delivery system. And sometimes they have spacers. The biggest thing about these inhalers or puffers is coordination. Hello, please. Hello, please kindly mute. Hello. Hello, who's off mute? Thank you. All right. So that's what was I? So the big thing about this, especially in pediatrics, is giving the proper instructions to your patient, because you know a lot of times the medication can end up in the mouth and then cause a whole bunch of oral problems here because the medication needs to go all the way down and inside the lungs, and that requires a little bit of training. That requires a little bit coordination. If you're in my pharmacology class, we'll definitely go over that like week 6, week 7 or so. Righty. And like I stated, around week 5, we're going to be starting looking at these cases. But if we look at, just briefly looking at this case right now, it has a subjective, objective, has some sort of assessment right here, the diagnosis, and a plan. What do we plan to do? And these are the meds, and that's a plan. So there's the subjective part, which is the history. There's an objective part, what kind of labs we did, right? What did we do? So take a brief look at it, but definitely look at the medical terms here that are associated with it. And in week 5, we're going to start looking at all these cases. But right now, what's more important is the medical terms. And if any of you noticed, I don't need any more notes because ever since last week, if you notice at the end of every chapter, they have the complete list of all word elements, meanings. So don't you think you could make your own quiz, multiple choice, and preempt me? And where do you think I got all the notes from? Where do you think I got all my questions from? I look at this and I just make up a question. A, B, C, D. All righty. So that's pulmonology. Thank you for those of you who submitted questions. And let me look at, because a couple more people hopped on. And let me see. There are 14. So there's 13 people. So let me count. If I have everybody. So that's 1, 2, Ms. Jones, I got you. Ms. Vargas, did I get you? Yes, I did. And Ms. Bangura, I got you. Ms. Kamara, I got you. So let me count. How many again? There's 14 people, so there should be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. All right, I got everybody. So I got everybody. So it's at this point, I am going to